Well, good afternoon or good morning to all of you, and thank you for joining us for this webinar today, put on by the Center for Health Equity Action for System Transformation here at Families USA. Today we'll be talking about how we can accelerate the achievement of health equity by measuring and paying for it in value-based programs. Just a few housekeeping issues to get out of the way. First, we are recording today's presentation so that we can make it available as a resource for you to refer back to, and for folks who weren't able to join us today. Feel free to type your questions into the chat box at any time during the presentation. If we can, we'll weave in answering your question into our presentations as we go along, but if not, we'll be sure to leave plenty of time at the end for questions as well. Just to give you a quick overview of what we'll cover today, we'll do a brief introduction of our speakers and of the Center for Health Equity Action. Then we'll look at opportunities to measure and pay for equity at the federal level, followed by a discussion of what that looks like at the state level, in California specifically, followed again by some time for Q&A. So my name is Ellen Albritton, and I'm a Senior Policy Analyst here at Families, and I do a lot of work with our Center on Health Equity Action. And I'll be talking today about some of the federal level policy options. And we're honored to be joined by Kerry Sanders, Senior Director of Federal Policy at the California Pan-Ethnic Health Network. CAPEN does incredible work on this issue on multiple fronts in California, and has also been a key partner for us in our Health Equity Task Force for Delivery and Payment Transformation. We launched the Center on Health Equity Action for System Transformation in December because we knew that there wasn't enough of a focus on how current system transformation efforts are impacting equity, and so many of these decisions about new delivery and payment models are being made without any engagement of or input from communities that are most affected by these inequities. So through the Center, we're building a movement to ensure that those communities are engaged and to be sure that we're implementing new innovative policies that will have a real impact on equity and that really center equity on their new design for delivering and paying for care. And here are just a few of the initiatives that are under our Center on Health Equity Action. I've already mentioned the task force. We also have one on evidence for equity focused on improving our evidence base. We provide strategic guidance and technical assistance to state and local partners. We have a Health Equity Action for Transformation Network to help us build a movement and bring in more people into this work. Our Community Health Worker Sustainability Collaborative that works on improving sustainable Medicaid financing for community health workers, and our Health Equity Action for Transformation Academies, which we'll be announcing formally and you'll be learning more about soon. All right, so a lot of today's discussion will focus on data and measurement and quality measures. So I just wanted to start with a brief overview of what are quality measures and why do they matter so much for equity. Quality and performance measures are ubiquitous in healthcare. Physicians, hospitals, health insurers, Medicaid programs, they all have to report them and are evaluated on them for a variety of reasons. Contracts between government programs and health plans or providers often have minimum quality standards that must be met in order for those contracts to continue. And increasingly, they are used to adjust payments to providers and plans. So this might mean getting additional bonus payments if you meet certain high quality or quality improvement targets. Many accountable care organizations, for example, or other new payment and delivery models have a minimum quality standard that providers or the other organizations participating in them must meet before they can share in any additional savings for a shared savings program, for example. But so far, these quality measurement initiatives, like much of health system transformation, hasn't focused enough on equity. So quality measures could be leveraged to accelerate reductions in inequities, or it could actually make them worse. So if we're just measuring providers based on their overall quality measures, and we aren't stratifying those measures by race and ethnicity, or disability status, or other measures, we actually may be incentivizing and rewarding providers for focusing on those patients who face fewer socially constructed barriers to good health. And then those providers who are serving those patients might actually end up getting financially penalized if we aren't taking an equity lens to our measurement initiatives and to our risk adjustment, which would just take resources away from communities that are often already very much under-resourced. And at the heart of all of this is really understanding that quality of care, even really good overall, quality of care does not mean that everyone is receiving that level of care, or that everyone is, or that care is being delivered or experienced by everyone in an equitable way. And this really was the assumption for a long time in a lot of our healthcare quality improvement efforts. As just one data point shows us, though, that this isn't true. And if we look at the states here on the left with the highest overall quality of care, the best quality, those are in blue on the map on the left. But some of these blue states actually do the worst when it comes to disparities. And those are the states that are in gray on the right. So if you look at, I believe Wisconsin and Pennsylvania they're in blue on the left, showing that they have the overall highest quality of care. But they actually do worse when it comes to inequities in that care. So two broad policy options that we'll talk about again and again as opportunities to use measurement to advance equity is that measures really need to be stratified by race and ethnicity at a minimum, as well as by language and disability and other important factors. That'll help us make sure that, one, we're accurately measuring where disparities exist, that we're monitoring what is happening to those disparities as we implement these new payment and delivery models, and it allows us a chance to really target those disparities as we enact new interventions as part of these models. And then second, we need to directly incentivize the reduction of disparities. So instead of saying, we'll give providers a payment bonus if they can get 90% overall on a quality measure, what if we require that they demonstrate that 90% overall, but for each racial and ethnic group, or that they demonstrate that they have narrowed the gap year over year in those disparities? And one place where the federal government could be doing much more to push those types of solutions forward is through the Center for Medicare and Medicaid Innovation, or CMS. Just a little background here. CMMI was created as part of the Affordable Care Act, and it is a part of CMS that is charged with testing new ways of delivering and paying for health care. And its statutory charge is really to lower the cost of health care while either keeping quality constant or improving quality. So the focus really is on cost, and there is no express inclusion of equity at all. However, CMMI has taken some steps to better integrate an equity analysis into individual grant awards or at the individual awardee level. One example of this is that CMS has developed a tool for assessing disparities and does encourage awardees to use it, and did in one case require it as part of the scored application for the Accountable Health Communities model, which is a model released in 2016 that was really focused on the social determinants of health. And there are a ton of different models that CMMI has implemented, and they all work a little bit differently. But many of them, particularly the ACO models, incentivize providers to better coordinate care and manage chronic conditions as a way to reduce costs. And if they reduce these costs while still meeting those minimum quality standards, they can share in a portion of those savings. And then for some models, if they don't meet those spending targets, they may actually have to pay a financial penalty back to CMS. But again, the quality targets for all of these models are aggregated just at that overall level, not on anything that is stratified by race or ethnicity or any other key factor in determining that we know can influence outcomes. And there is no direct incentive to reduce disparities. And again, in fact, there may actually kind of inadvertently be incentives to avoid complex patients, which may have the effect of exacerbating disparities. And we really see that this is a missed opportunity for CMMI to really drive us towards more equitable healthcare. So we reviewed the annual and final evaluation reports for a number of these different CMMI models, and they don't stratify any quality outcomes at all. In fact, if you look at these reports, you can really tell that the focus is really on lowering cost, and there's less attention given to the effects on quality. And then within the quality evaluations, again, there's really nothing to look at how people of different races or ethnicities or primary language are being impacted by these models. For the Medicare Shared Savings Program, which is the largest ACO model, they do have publicly available data files you can download to look at the ACO level to see how they scored on each quality metric. But again, none of that is stratified. And even for the ACO investment model, which is a program specifically focused on helping ACOs develop in underserved communities, those outcomes weren't stratified either. And this is especially concerning because we already know that there's already studies that show that ACOs that serve a higher proportion of people of color are scoring lower on the overall quality measures, and some evidence that the people who are benefiting most from improvements in care in some of these ACOs are the folks who are already at lower risk, and the folks who are at higher risk aren't benefiting as much. So there's a real danger here that we are maybe exacerbating disparities, but we're not fully capturing what's happening. The CMMI isn't the only place where the federal government can do a lot more to achieve equity using quality measurement. CMS also regulates and oversees a few different types of health plans, and there are already quality standards in each of these as well. So there are three main types of exchange or similar structures that are relevant for our conversation here. There's, of course, the qualified health plans that are part of the ACA marketplace, but there's also a lot of private health plan involvement in Medicare through Medicare Advantage and through Medicare Part D. And for each of these types of plans, CMS has created a 5-star rating system based on quality performance. And these ratings are publicly reported and are supposed to be used by consumers to help them choose a plan that they feel is best for them. So for all of these, there's a consumer-facing website where you can go and show plans that are available in your area, and you can look at their overall quality score, and you can also break it out into kind of the component parts, you know, how they do on quality in particular, clinical outcomes, or access to care measures. But again, we know that there are some missed opportunities here as well for equity. So in the past few years, CMS has taken some important steps by releasing national level reports that look at disparities in Medicare Advantage and by making contract level data available for download that actually does stratify these measures by race and ethnicity. So it could have been a really great opportunity to start to get more of that granular information about what is happening at that level. However, if you download this data, you'll see that for many of these measures, for many, if not most plan contracts, there's actually no data available on quality measures except for white beneficiaries due to small sample sizes or other data reliability issues like having a large number of beneficiaries who haven't self-reported their race and ethnicity. And that's something I think Cary will talk a little bit about more too, just kind of some of the data problems and the importance of self-reported data. And keeping our focus on Medicare Advantage, there's some really important financial incentives on the line depending on how many stars a Medicare Advantage plan receives. So 4- and 5-star plans get billions of dollars every year in bonus payments. They're able to enroll throughout the year, so they kind of have an advantage over other plans in increasing enrollment. And low-performing plans kind of get this extra warning symbol on that consumer-facing website to warn people that they have lower quality. But again, none of these initiatives incorporate a disparities lens or an equity lens. So even if we had really good stratified data on race and ethnicity that showed that a plan had really big disparities in some of their quality outcomes, that would not affect their star rating, and it wouldn't affect whether or not they got the bonus payment. And importantly, it also means that beneficiaries of color are left in the dark about which plans do the best job of serving them and their communities. So there's lots of work to be done at the federal level, and again, we really are focusing, coming back to those two policy options of making sure that all measures are getting stratified by at least race and ethnicity, and integrating some specific direct incentives on providers and other organizations to reduce disparities. But there's also a lot that can be done on the state level, and for that, I'm really excited that Cary is with us to talk about all the different opportunities that you might be able to do in your own state. So with that, I will turn it over to Cary.
Hi, everyone. Hopefully you can hear me. This is Kerry Sanders, Senior Director of Federal Policy for the California Pan-Ethnic Health Network. Our Executive Director, Sarah DeGia, who serves on Families USA's Health Equity Task Force, couldn't make it today, so I'm stepping in for her. Wanted to just start off by just saying a little bit about CAPEN and our work. We're a statewide multicultural health advocacy organization founded over 25 years ago, and our mission is to ensure health justice and equity are on the agendas of policymakers, and that communities of color are really leading policy efforts. And we do that through legislative advocacy, our community advocacy work, working with our networks, our local regional partners through our Having Our Say Coalition, Behavioral Health Equity Collaborative, and Oral Health Network. And then also just connecting data, stories, and regions to build knowledge and relationships and understanding across outcomes. Families USA's new issue brief, Accelerating Health Equity by Measuring and Paying for Results, is exactly what we need to be focusing on right now. As quality measurement is increasingly used to determine payments to providers and health plans, not measuring and paying for equity risks worsening disparities or masking them, and it's a significant missed opportunity. But there's a lot we can do to change these policies. I'm going to talk today about 4 specific examples in California of how state advocates and policymakers are working together to measure and pay for health equity. And that's through our Medicare program, which is Medi-Cal. Our state marketplace, state exchange Cover California, through our state public health department, and through our safety net hospitals. In California, the ACA substantially reduced health disparities for communities of color in health in coverage, but not in terms of health outcomes. In California, Latinos and African Americans have twice the prevalence of type 2 diabetes and are twice as likely to die from the disease. American Indians and Alaska Natives are 3 times as likely to have asthma than the state average. And African Americans have exceptionally higher rates of asthma prevalence, 40%, or 4 times higher asthma ED visit and hospitalization rates than others. Our Medi-Cal program, thanks to the ACA, now covers 14 million Californians, or a third of the state, more than half of all kids, and in certain counties, nearly 1 in 2 adults are insured through Medi-Cal. Similarly, our state exchange covers 1.3 million Californians, 90% of whom receive federal subsidies. 80% of our enrollees in Medi-Cal and 66%, or 2/3 of enrollees in Cover California, are from communities of color. Because of this diversity, using measurement to advance health equity must be a part of quality improvement and health systems transformation efforts in these programs. In the Medi-Cal program in particular, in 2013, before the ACA, CPEN advocated for passage of a bill that would have required the collection and analysis by our state's external quality review organization of Medi-Cal data by race, ethnicity, and language. The bill, while not signed, was later adopted by our Department of Healthcare Services as part of which administers our Medi-Cal program as part of its contract requirements for managed care plans. It took 3 years to produce the first report, but it's finally available. And the first report analyzed 12 external accountability set metrics, or HEDIS or CAPS metrics, that corresponded to key areas, the following 4 key areas: care for children and adolescents, women's health, including prenatal and postpartum care, care for chronic conditions, including diabetes and asthma, and appropriate treatment and utilization. And when you look at the results, the first report found disparities across the board, particularly for African American communities, but also for other communities of color. Unfortunately, the results also revealed that the data collection from managed care plans was not as up to par as it should have been. In particular, for example, 3 managed care plans reported that 100% of their members had primary language variables missing. 8 managed care plans reported that more than 10% of their members with the primary language variable missing also reported that their race ethnicity variables were missing. Additionally, the data was too small to show trends or disparities for smaller subpopulations like Native Hawaiian and Pacific Islander populations, which made it very difficult, or will make it difficult, to measure and act on disparities within those groups. Administrative and legislative efforts are still continuing to improve this. And moving forward, DHCS, our health agency, does plan to require managed care plans to report annually on disparities data for all 30 of the EAS metrics. And we are working on legislation to require the addition of data on sexual orientation and gender identity as well. In Cover California, another effort, Cover California is an active purchaser, which means it can choose which plans participate in the exchange and negotiate rates, standard benefit offerings, networks, and quality strategies to get the best value for consumers. To date, Cover California has worked with consumers and stakeholders to identify metrics to measure disparities reduction in 4 key areas: diabetes, hypertension, asthma, and behavioral health. It has also convened QHPs and academic experts to share best practices on data collection and provided technical assistance to QHPs on how to report on the specific disparities reduction metrics, as well as integrated health systems or worked with health systems to encourage them to better integrate their electronic medical records and other records in order to share and report on data. Early results of the initiative are promising. 9 of 11 qualified health plans in Cover California have increased their data collection capacity. More than half have met or exceeded targets for self-reported data by race and ethnicity. Cover California is working with QHP issuers to analyze condition-specific data in those 4 areas that I identified and to address challenges related to data quality moving forward. Additionally, advocates are working to strengthen the public reporting process through a legislative effort and are working with Cover California to ensure that we can report that data. 2 other examples that I wanted to point to. So in 2015, CAPEN worked with other advocates for API communities, Asian Pacific Islander American Health Forum, EPIC, and the Southeast Asia Resource Action Center to expand the demographic data categories for Asian Pacific Islander communities in California. We worked on a bill because of wide variations in health outcomes in California. Some API communities often appear to be doing better than other communities. No one is really stratifying the data and really looking at individual differences between smaller subpopulations. So we worked on this legislation that requires the Department of Public Health to report health outcomes for additional ethnic groups whenever they are already collecting demographic data for their reporting, which includes reports on major diseases, cause of death in California, pregnancy rates, or housing numbers. The legislature was very supportive, and we were able to get the bill signed. We did experience some unlikely opponents, in particular in California, the Chinese American community, who saw the bill as a threat against achieving equality. However, we were able to work with supporters, including community members from some of the communities who are not currently counted in a lot of these surveys to really counter that message. And in the next slide, you'll see these are some of the additional categories that we were able to add. So, for example, we have an emerging Hmong community in California that has really grown and is located in sort of key regions in the state, and they were particularly invested in pushing for better data collection and better resources targeted to those communities. And then the last effort I just wanted to highlight, as part of our 1115 waiver, our Department of Healthcare Services is working with so state policymakers are working with our safety net public hospitals to improve their reporting of race, ethnicity, and language data, as well as data on sexual orientation and gender identity. And what they did as part of the waiver was to establish baseline data and then pay for these public hospitals to improve their reporting on this data, race, ethnicity, and SOGI data, by setting concrete targets over the 5-year period of the grant for the public hospitals to meet. And you can see how the targets are progressive. So year 1, it's 20% for race, ethnicity data. and then eventually it moves up to 80% by year 5. For SOGI data, it begins at 10% and moves up to 40% by year 5. And from what we have heard so far, the public hospitals are making great strides and efforts in improving their ability to collect this data. So just a couple of closing thoughts on all of this. We have in our advocacy used different types of advocacy to really advance data collection efforts. Starting with the Medi-Cal example, we started with administrative, then we had a bill, and then we worked back to administrative advocacy. A lot of the ways that we have been most successful has been working with policymakers to really educate them about the need for this type of data. We've also been able to elevate the use and collection of self-reported data as a best practice. We know that this is the best way to get this data is for folks to self-report as opposed to health workers guessing a person's race or ethnicity. And then we've also there is the importance of regional and local variation. In California, we have many different emerging communities, and so the level of data that we have collected in the past has necessarily changed based on new communities and regional differences. And so we do try to focus on that. It's important to think about that in these conversations. Also important to consider unlikely allies and also opponents, and try to think about how to work with and educate and continue to move these issues. And then the last thing I would say is, oftentimes when we start to have these conversations, we hear that it's just impossible. Health plans, providers are very good at saying that it's just impossible to get this information, and we find that by focusing on both incentives for the collection and reporting of this data, but also on health outcomes, improving health outcomes, that really helps to gets everyone at the table to really have these conversations and move beyond the resistance and barriers. So thank you. That concludes my remarks for today.
Great. Thank you so much, Cary. Just a reminder that feel free to type your questions in the chat box, and we will be sure to answer them. We've got plenty of time left for questions. I will start off with a question for Cary. What do you think what has been the most surprising aspect of your advocacy on this issue? Maybe it's a counter argument that you hadn't anticipated or been ready for, or most surprising partner or result that's come out of this work. What has most surprised you?
That's a great question. I think definitely when I touched on our efforts around API data disaggregation. I think we were really surprised to see that there was some opposition within some of the communities that we were working with, and I think part of that is was just some miseducation or misinformation about and kind of some stirring up about concerns that disaggregated data could be used for negative reasons. Whereas I think the biggest issue and the biggest problem, particularly for API communities, is the lack of data. And so being able to expand those categories and work with the communities on the ground to try to counteract that was really, really important for those communities in order to really be counted and have their issues addressed.
Great, thank you. We have a question from Stephen Wagner, and he asked, were there non-health reasons behind your choosing the health outcomes you did, the outcomes that you were asking for mitigation of the health disparities?
Well, we've asked for a number of a number of different types of metrics and disparities outcomes reduction. I think for the Medi-Cal program, we had some evidence of disparities, for example, in chronic conditions, in asthma, diabetes, mental health, and hypertension. So, over the years, while it wasn't disaggregated by regional levels, we knew that there were certain populations where where disparities were staying the same, or in some cases worsening. And a lot of the conditions that I think we've chosen to focus on are conditions that may be preventable if enough attention is really paid to preventative care and to improving health outcomes. So that was a big motivation for that. I think on the public health side, the areas of focus, the initial legislation and effort was really broad and focused not just on health but across the spectrum in other areas, including other social determinants of health such as housing, education, environment, and other data surveys. That effort was narrowed to kind of what you see today, but I think there is interest in, really ensuring that we're also looking at social determinants of health when we're talking about data disaggregation as well.
Great. Do you have anything to report about how the information that is coming, the additional information you're getting about what disparities exist and exactly what they look like, has that been able to be used to design interventions to specifically target reducing those disparities?
Absolutely. In California, in the Medi-Cal program, and I think in Covered California as well, we're, with some of the disparities data, so just a couple things. In Medi-Cal, they're going to use this health disparities report to get baseline data. Their goal is by for the 2018 measurement year to require their health plans to report and stratify data for all 30 of their external accountability set metrics. So plans will be required to report on stratified data for every member. Currently, there's a requirement that managed care plans have at least one of their improvement programs focus on a disparity, eliminating a disparity, and so that is a requirement. But I think the plan is moving forward as the state begins to collect and have baseline, at least 3 years of baseline data to look at, that the state will then hopefully begin to require more targeted interventions geared at reducing those disparities. And then I would just say similarly, Covered California's initiative, they are working with health plans. They have identified areas where there are disparities, and the next step really is on trying to think about and decide on appropriate interventions to reduce those disparities.
Great. Are there any initiatives underway now or that are being talked about where you would have this pay for performance based on their performance on reducing disparities?
So Covered California's current disparities reduction requirements are actually include a pay for performance. So health plans, qualified health plans, receive a additional bonus if they exceed the specific targets around disparities reduction. They can also receive a penalty if they fall below their specific targets for disparities reduction. The implementation part, I think, is still in the works. So, we're still learning more about, the specifics, plan by plan specifics of what's happening and how these are being applied. But that is part of the contracts. And then we also have an effort, with our state Medi-Cal program, we have a state bill, AB 537, which would require managed care plans to show year-over-year improvement in disparities reduction. And we are hearing from the state that they are also, I think they have signaled that they're also interested in moving in that type of, similar type of direction as well.
Great. If you were what would you say to an advocate in a state that doesn't really have any kind of this stratification happening, or is really only collecting like very, very aggregated data? What's the best place to start?
That's a great question. Frankly, I think part of it has to be, through setting baselines and sort of working your way and progressing through measurement. If you look at the public hospital example, as an example, I think you can see that the state was able to use, part of it is providing resources, so the state was able to use 1115 waiver dollars to basically pay for their public hospitals to upgrade their reporting systems to be able to better collect this data. I think in a managed care world, I would argue that managed care plans, at least those in California, are actually making a profit for providing the Medi-Cal services that they provide, and therefore, they should be required to develop those systems internally to collect that data. But having said that, I think having state policymakers set those, require baseline data and then begin to set those specific performance targets is a really important way to get there. And on the back end, if you look at what Cover California has done, they have backed up those targets with technical assistance, providing QHPs with access to data analysts, folks from the RAND Corporation and from other academics to really work with health plans to figure out how they can meet those performance targets.
Great. Well, I'll make one last call for questions. If you have any, please put them in the chat box and we will make sure to have them answered. If you're interested in learning more about what states can do on this issue when it comes to measure stratification and data disaggregation and how they can incorporate that into pay for performance and other similar initiatives, we encourage you to check out the issue brief that Families USA recently released as part of this work. That looked at some of the stuff that Cary talked about, but it also looks at the CCO effort in Oregon. They've been doing a lot of measure stratification in their pay for performance initiative and have some new ideas about how to really link that more to payment in their next iteration of the CCOs. So please do sign up for our Health Equity Action for Transformation Network to stay connected to the work that we're doing. You'll hear about webinars like this one. You'll hear about issue briefs and other opportunities to engage with us, to receive technical assistance if this is something you're interested in your state. And with that, we can end our webinar today. Please do fill out the survey that should automatically pop up when you close the webinar window. And thank you again to Cary for joining us and sharing with us your learnings from what is happening in California. Thanks, everyone. Have a good afternoon.